everyone. So today we'll discuss the part 2 of the crash course of physiology, that is the blood chapter. So firstly, what is the formation and the functions of the plasma proteins? So over here the formation of the plasma protein in the embryo. So in the embryo the mesenchymal cells forms the plasma proteins, and over here firstly the albumin is synthesized and rest of the plasma proteins are synthesized later on, while in the adults albumin is formed from the liver. Same way the fibrinogen is also formed in the liver. The globulin is synthesized from the tissue macrophages, plasma cells, and the lymphocyte synthesizes the gamma globulin. Now very important, plasma protein functions. What are the functions of the plasma protein? So exerting the osmotic pressure. The plasma proteins are responsible for exerting the osmotic pressure of plasma, which influences the exchange of the fluid between the blood and the interstitial fluid. Now over here the magnitude is around 25 mmHg, and the albumin contributes the major portion towards the osmotic pressure. Very important. Now next function is the viscosity. Plasma proteins along with the blood cells provide the viscosity to the blood, which maintains the peripheral resistance, and hence the arterial blood pressure is also maintained. Now over here fibrinogen, because of its shape, contributes as much as albumin, though it is present in smaller amounts. So remember, the osmotic pressure is majorly exerted by the albumin, while the viscosity is done by both fibrinogen as well as albumin. The next function is the transport function. Plasma proteins combine loosely with many chemicals, transports them, release them slowly, also acts as their reservoir and even prevent their excretion. For example, albumin, alpha globulins, beta globulins, and the gamma globulins. Now buffering effect. In alkaline medium, plasma protein partially ionizes as acid and donates the hydrogen ion. Not only this, but also they can also accept the hydrogen ions if the plasma becomes acidic. So they act as a very good buffering agent. So they act as blood buffers and account for around 1/6 of the buffering power of the blood. Now the antibodies. Gamma globulins or the immunoglobulins, now they are formed by the B lymphocytes in response to specific antigens and destroys them by antigen antibody reactions, protecting the body from the harmful effect. Now carrier for lipids. Even plasma proteins acts as a carrier for lipids. Lipoprotein in the globulin fraction acts as carrier of the cholesterol, phospholipids and free fatty acids, and even transport them in the blood. Blood coagulation mechanism, that is the hemostasis. Fibrinogen and the prothrombin are essential for blood clotting mechanism, and hence hemostasis is maintained. Now the difference between the myoglobin and the hemoglobin. Now over here remember, myoglobin is an iron containing pigment found in the skeletal muscles, while the hemoglobin is found in the RBCs. They are found in the red blood cells. Okay. Now over here the myoglobin binds to 1 mole of oxygen, while the hemoglobin binds to 4 mole of oxygen. Hemoglobin is 4 times higher in the molecular weight as compared to the myoglobin. Okay. Now one question for you. Is reduced hemoglobin a better buffer than oxyhemoglobin? What do you think? Yes or no? If yes, then why? Just answer me this question in the comment section, and I will give you the answer of this question in my next video description box. Okay. Till now think about this question. Think about the answer of this. Now this is the oxygen hemoglobin dissociation curve. Okay. This is the sigmoid shape curve over here. Now as you can see, this myoglobin over here, this is the myoglobin curve, which is forming a rectangular hyperbola over here. So its curve, the myoglobin curve is to the left side of the oxygen hemoglobin dissociation curve and is having the structure rectangular hyperbola, commonly asked in the exams. Okay. Now one more important thing, that this myoglobin takes up oxygen at a very lower pressure as compared to the hemoglobin, right? So that's why it is found in the skeletal muscles specialized for sustained contraction, where the partial pressure of the O2 is close to 0. while this hemoglobin takes up oxygen at a very higher partial pressure. That's why this hemoglobin is very important, and even this hemoglobin plays a very vital role in transporting the oxygen from the lungs to the tissue because of its characteristic that it takes up oxygen at a very higher partial pressure. So this curve is very important. Now next, erythropoiesis. Now first of all, what is erythropoiesis? Erythropoiesis is a very important, is a very vital process of formation of the red blood cells in the body. Now one more important thing, that what is the location of this erythropoiesis process in the body? So remember, in the fetal stage, what is fetal stage? Means around till the ninth month, it is the fetal stage, right? So in the first 3 months of the fetal stage, mesoderm causes the erythropoiesis process, while from 3rd to 6th month, liver causes the erythropoiesis. In the liver, the erythropoiesis process occurs, while in the rest months, that is the 7th to 9th months, 7 to 9 months, bone marrow plays the important role in the erythropoiesis process. So remember, in the fetal stage, that means up till 9 months, from 1st to 3rd month, mesoderm, from 3rd to 6th month, liver, and from 7 to 9th month, bone marrow, okay, in the fetal stage. Now what happens, where does this erythropoiesis occurs in the child? Means up to around 20 years of age. So bone marrow of all the bones, liver and the spleen plays the vital role in the having the process, that is the erythropoiesis. Okay, so bone marrow of all bones, liver and the spleen up to 20 age, and after the 20 age, means in the adult stage, bone marrow is the only place where the erythropoiesis process takes place. Okay, now this process over here, this is the whole stages for the formation of the red blood cells finally. So this RBCs originates from the pluripotent stem cells and further passes through successive stages to end up in the formation of the red blood cells. So first of all, there is pluripotent stem cells, then the pronormoblast stage, then the early normoblast, then comes the intermediate normoblast, then the late normoblast, then the reticulocyte stage, and then finally the red blood cells. Okay, so let me show you one more diagram over here. So this is the pluripotent stem cell. Then comes the pronormoblast stage. Now over here, after pronormoblast comes the early normoblast, also known as the basophilic erythroblast stage. Okay, now why it is called so? Why basophilic erythroblast? Firstly, over here, remember, in this stage there is higher nucleus to the cytoplasm ratio. In this stage there is higher nucleus to cytoplasm ratio. Also the chromatin over here in this stage condenses, and this the cytoplasm is basophilic. That's why this is known as the basophilic erythroblast, or we can say the early normoblast. Over here, as the cytoplasm is basophilic, it is known as the basophilic erythroblast. Now over here next comes the polychromatic erythroblast, also known as the intermediate normoblast stage. Now over here, what happens inside this particular cell? Over here there is clumped chromatin seen, plus there is no nucleoli. In this stage there is no nucleoli present. Now also, very importantly, the cytoplasm over here is grayish in color. Okay, now why this cytoplasm over here in the intermediate normoblast stage or the polychromatic erythroblast stage, why the cytoplasm is grayish in color? Very important question. Because over here the hemoglobin is start to be seen. Okay, hemoglobin is seen in this stage. That's why the cytoplasm becomes grayish in color. So first hemoglobin is seen in the intermediate normoblast stage, that is a polychromatic erythroblast stage. And one more important thing, the cell division ceases from this stage. Okay, and polychromasia is seen. Okay, that's why the polychromatic erythroblast. Now next is the orthochromatic erythroblast, also known as the late normoblast. Early normoblast, intermediate, and then the late normoblast. Now what happens in this stage? There is densely pycnotic nucleus seen. Also, there is well hemoglobinized cytoplasm is seen in this stage. That's why cytoplasm is somewhat reddish in color. Okay, it is not seen reddish in color over here, but it is somewhat reddish in color because well hemoglobinized cytoplasm is seen at this stage. So remember, firstly, the hemoglobin is seen at the intermediate normoblast stage. Okay, and over here the cytoplasm is grayish in color, while in this late normoblast stage, the cytoplasm is well hemoglobinized. Okay. Now next comes the reticulocyte stage. Now this reticulocyte stage over here, in this stage, remember, the nucleus is extruded. That's why in this stage you can't see the nucleus, because in the reticulocyte stage the nucleus is extruded. The cell removes the nucleus from it. Okay, so in the reticulocyte stage there is removal of the nucleus, and then finally the erythrocytes formation occurs. Now some more important points. Pro-erythroblast, that is the pro-normoblast stage. Over here, most important event occurring is the synthesis of the hemoglobin starts. So over here, remember, the synthesis of the hemoglobin starts from this stage, from the pro-normoblast stage. Okay, but the first hemoglobin, okay, the hemoglobin starts appearing from the intermediate normoblast stage. Remember, the hemoglobin is appeared in the intermediate normoblast stage, while the synthesis starts occurring in the pro-normoblast stage. So remember this difference. Pro-normoblast, synthesis of the hemoglobin starts, while in the intermediate one, hemoglobin starts to be seen, starts appearing. Okay, and that's why the cytoplasm appears grayish in color. In the early normoblast stage, basophilic one, the nucleoli disappears. I told you before also. Late normoblast stage, over here the nucleus disappears. Reticulocyte, reticulum is formed. Cell enters the capillary from the site of production, and the mature RBC reticulum disappears and cell attains biconcavity. Okay, so this was the whole concept of the erythropoiesis. Now some more important things. Now through what changes does the cell undergoes during the erythropoiesis process? So let's go in a quick manner. It decreases in the size, the cytoplasm increases in the amount, and the nucleus decreases in size. Nucleoli disappears, chromatin becomes progressively coarser, nucleus is gradually lost, and also staining reaction of the cytoplasm changes from deep basophilic to polychromatophilic and then the acidophilic due to the gradual reduction in the amount of RNA. We discussed about this before also, right? Now next, that is what regulates the erythropoiesis process. So general factors, that is the hypoxia, and the specialized maturation factors, which includes three further topics, that is the dietary factors, Cassell's intrinsic factor, and the extrinsic factors. So first of all, general factors, which includes the hypoxia. Now how hypoxia can cause the erythropoiesis process, or how can it stimulate the erythropoiesis process? So hypoxia is the most potent stimulus for the formation of the red blood cells. How? It causes the stimulation of the bone marrow, increasing the RBC's production. Okay, and this effect is mediated by what? By the erythropoietin. So this hypoxia, what it will do? It will stimulate the bone marrow, which further increases the RBC's production, and this effect is mediated by the erythropoietin. Now this erythropoietin is also known as erythrocyte stimulating factor, or we can say erythropoiesis stimulating hormone. You can easily identify its function by its name itself, right? Now source and the metabolism. 85% is secreted by the kidneys, probably by the interstitial cells of the peritubular capillaries, and the rest 15% is produced by the extrarenal sources, liver parenchymal cells, and the tissue macrophage system. Now, as you can see over here, 85% is secreted by the kidney. So, hypoxia of the kidneys causes the releasing of the renal erythropoietin factor, or the erythrogenin. Okay, that acts on the plasma substrate, that is the erythropoietinogen, which is an alpha globulin to form the erythropoietin and to stimulate the erythropoiesis process. Now next, special maturation factor. Firstly, it includes the dietary factors. Globin helps in protein formation. Iron, manganese, copper, cobalt, nickel helps in the heme formation. Calcium increases the iron absorption from the GIT. And the vitamin C, vitamin B12 and the vitamin B9 helps in the synthesis of the nucleic acid. Now next is the Cassell's intrinsic factor. Now this is what? This is a glycoprotein secreted by the parietal cells of the stomach, which helps in the absorption of the vitamin B12 from the stomach, right? Now one molecule of intrinsic factor combines with one molecule of vitamin B12 that binds to specific receptors in the ileal mucosa, and the intrinsic factor splits from the complex and vitamin B12 is released into the portal blood. This process does not require energy, but this process is what? It is calcium dependent, occurring optimally at optimal pH. Now, extrinsic factors include, they are present in certain foods and essentially folic acid and vitamin B12 only. You know about this. Intrinsic factor along with the extrinsic factor forms the hematinic principle, which helps in the maturation of the RBCs. Therefore, deficiency of any of these two leads to the maturation failure, and hence megaloblastic anemia occurs. I have made a separate video on the anemia, that is the megaloblastic anemia, vitamin B9 anemia, vitamin B12, iron deficiency anemia. I have made a separate videos on this, okay, in detail about them, because anemia is a very big topic. Okay, so if you want to know about the anemias, just click on this I button, okay, and you can just get onto the detailed video about the anemias, okay, because this is a crash course video, right? So I have to go a little bit faster. But if you want to know in detail about the anemia, just go on to the link, okay. I have given very easiest possible explanation about the anemias. Just click on this I button somewhere over here, okay. Now, what are the fate of the RBCs? The lifespan of the RBC, the mature RBC is around 120 days, remember, very important. Now, very common asked question, 2 marker or we can say 1 marker questions. Why does the RBCs cannot survive longer? So, because they do not contain the nucleus, mitochondria contain cytoplasmic enzymes capable only of metabolizing glucose by glycolytic processes, and thus they generate very few ATPs, and that's why the RBCs cannot survive longer. However, this metabolic system becomes progressively weaker with time, and as a result of this, what changes takes place in the RBCs? So, flexibility of the membrane decreases. Also, transportation across the membrane occurs. A lot of transportation occurs. That's why ionic composition in the cell cannot be maintained. Keeping the iron of the hemoglobin in the ferrous state becomes difficult, and also inhibition of the oxidation of the protein in the RBCs cannot be maintained, which leads to the destruction of the RBCs. Now, what happens after the RBCs breaks down? So, RBCs, the red blood cells, breaks down and they release the hemoglobin in the reticuloendothelial system, which then further converts into the biliverdin and then into bilirubin. Now, this unconjugated bilirubin is then transported to the bloodstream, enters the bloodstream. Now, after entering into the bloodstream, bilirubin, this unconjugated bilirubin binds to the albumin. Now, as we all know that albumin is a plasma protein and acts as a very good transporting material. This albumin is a very good transporting plasma protein and helps in the transportation of the bilirubin towards the liver. Now what happens? This unconjugated bilirubin is converted to the conjugated bilirubin in the presence of the enzyme UDP glucuronide transferase enzyme, and now this conjugated bilirubin is either excreted in the urine or it then further enters the bile, okay, where this conjugated bilirubin enters the bile, and after entering into bile, where it will go? It will go in the small intestine. Now, in the small intestine, they further converted into urobilinogen, which further converts into urobilin or the stercobilin, which gives the color to the feces and excreted in the feces. Or even this urobilinogen may enter further into the liver also, enterohepatic circulation. So this is the fate of RBCs. What happens after the breaking down of the RBCs? Okay, this is the most common thing that you should definitely know. Okay. Now, this is also important in the jaundice part also. Okay. So, let's go into the theory part. The cells progressively becomes more fragile and breaks down as they pass through the narrow capillaries, especially in the spleen, that is the reticuloendothelial system. As the cells are broken, their hemoglobin is phagocytosed by the reticular endothelial cells. Okay. Now we all know the red blood cells also contains the iron and the globin. Now the iron and the globin are removed and the remaining hemoglobin is converted into the bilirubin, okay, which is carried to the liver where it is conjugated. Over here I told you all these steps, right? Conjugated in the liver, okay, with the glucuronic acid and secreted into the bile, okay, and then further goes into the small intestine. In the intestine, it is partially reabsorbed and partially converted into the urobilinogen and the stercobilinogen by the bacterial action and lost from the urine and stool respectively. Okay. Iron and the globin are reused for the synthesis of the fresh hemoglobin. The rest of the bilirubin is reabsorbed and transported to the liver via the enterohepatic circulation. Now, one more important concept, that is a lab classification of the anemia, which includes the hemoglobin content of the patient blood, RBC count, and the hematocrit of the PCV, that is the packed cell volume. So over here you should remember the MCV, MCH, and the MCHC. Their formula, the normal ranges, commonly asked everywhere. Okay, everywhere. Now MCV, that is the mean corpuscular volume. As the name says, what it is. It is the average volume of the red blood cells. Its important formula, that is the packed cell volume per liter in the cubic microns upon RBC. This is the unit of the MCV, cubic micron or the femtoliter, cubic microns or the femtoliter, 10 raised to minus 15, 15, 10 raised to minus 15. Okay, the formula is packed cell volume per liter upon RBC count over here, okay, in the million cubic mm, million per cubic mm. So remember this formula, very important, PCV per liter upon RBC count in million per cubic mm. Now, this is the whole formula, that how does this normal range came from. Okay, the normal range is around 78 to 94 cubic microns or the femtoliter, that is 10 raised to minus 15, 10 raised to minus 15 is the femtoliter. Okay, so remember this formula, I am telling you again and again. This formula is very important, packed cell volume per liter upon RBC count in million per cubic mm. Okay, now next is, when the MCV is less than normal cells, it is known as microcytes, and anemia is known as the microcytic anemia. Common example, iron deficiency anemia. Okay, so I have made a separate video on the iron deficiency anemia. So just click on the I button somewhere over here, okay, and you can get the detailed information about the iron deficiency anemia, because anemia is a very big concept. Okay, so click on this I button and you will get the detailed video about this. Now, if the MCV is more than normal, it is macrocytic anemia. For example, folic acid deficiency or B9 deficiency and the B12 deficiency anemia. Again, I am telling you, I have made a separate video on the folic acid deficiency and the B12 deficiency anemia. Just click on this I button somewhere over here and you can get the detailed video of this. Now, the MCH, that is the mean corpuscular hemoglobin. As the name says, it is the average amount of the hemoglobin in the RBCs. Important thing, the formula, hemoglobin per liter, okay, in the picogram. This, the unit over here is the picogram, remember. In the MCV, we were having the unit as the femtoliter, while over here the unit is picogram. These units are very important. You should know about the units. Okay, so MCH formula, that is the hemoglobin per liter upon RBCs in million per cubic mm. Hemoglobin per liter upon RBCs in million per cubic mm. Just remember this formula is very important. So now the range to 29.5 plus or minus 2.5 picogram. Okay, this is a very important normal range, 29.5 plus or minus 2.5 picogram. Now this MCH may vary with the variation in the RBC size. The next comes the MCHC, that is the mean corpuscular hemoglobin concentration, that is the degree of the saturation of the RBCs with the hemoglobin. So over here the formula is the hemoglobin in gram per deciliter into 100 upon PCV. Now you can get it that it is in percentage. Normal range, it is around from 32 plus or minus 3, 32 plus or minus 3 percentage. So remember all this formula and the normal range is very important. Now, this MCHC in normal range is known as the normochromic cells. MCHC less than normal, it is the hypochromic cells, while MCHC cannot be more than normal. Remember, it can be normal or less than normal. The MCHC cannot be more than normal, as the hemoglobin saturation of the RBCs cannot be beyond a certain limit. So this line is very important. Okay. Now next, based on these indices, anemia can be classified as, it can be microcytic hypochromic anemia, including the iron deficiency anemia and the thalassemia. Now next is the macrocytic normochromic anemia, that is the folic acid and the B12 deficiency anemia, and the normocytic normochromic anemia, that is after acute hemorrhage, aplastic anemia, and all hemolytic anemias except the iron deficiency anemia. So remember all these important examples, very important. Now, hemolytic anemias. This is a type of anemia which is produced due to the destruction of the RBCs. Okay, so it can be due to intracorpuscular defect, extracorpuscular defect. Okay, so intracorpuscular defects are hereditary in nature. Hereditary spherocytosis are the example of this. Further, hemoglobinopathies like sickle cell anemia and thalassemia are also example of this intracorpuscular defects or intracorpuscular defect hemolytic anemia. Erythroblastoses fetalis, G6P deficiency. Now the extracorpuscular defects which is leading to the hemolytic anemia. Now they are not hereditary, they are acquired in the nature. Antigen antibody reactions are the example. Infections like malaria. Also, drugs or poisons like quinine, aspirin, etc. can cause such defects. Hypersplenism, which causes the overactivity of the normal destructive mechanism. Now, very important concept regarding the thalassemia, alpha thalassemia and the beta thalassemia. Now, remember on the 16th chromosome, 16th chromosome, 4 alpha globin genes are present normally. Okay. So, if all the 4 are present, then normal state. If 3 are present, only 3, 1 is absent. Okay, 3 are present, 3 genes are present, then the patient is a silent carrier but almost asymptomatic. Okay. If 2 genes are present and 2 are absent, then the patient is thalassemia, having thalassemia trait, thalassemia minor. If the patient is having only 1 gene present, then it is known as the HbH disease, also known as thalassemia intermedia, mild to moderate microcytic anemia seen. While if none of the genes, none of the alpha genes are present on the 16th chromosome, then that is the thalassemia major, that is the hydrops fetalis. Now the beta thalassemia trait on the chromosome number 11, 1 gene defect, intermedia 2 gene defects, and major 2 gene defects, while in the intermedia there is only mild to moderate decrement in the beta globin synthesis, while in the major there is severe decrement in the beta globin synthesis. Okay, asymptomatic, mild, over here major symptoms are seen in the major. Now next is the sickle cell anemia. As the name says, sickle cell, the RBCs become around sickle in shape. Okay, the RBCs become sickle in shape. So, sickle cell anemia, over here missense mutation occurs which replaces the glutamic acid with valine at the 6th position of the beta globin chain. Okay, at the 6th position of the beta globin chain. Now, what happens in this disease? Whenever there is hypoxemia or dehydration or acidosis occurs in the body, the HbS polymerizes, which further leads to polymer aggregation, polymers realignment, polymer aggregation, and further leads to needle-like structure formation of the RBCs. If there are 2 abnormal, or we can say 2 mutated beta genes present, it is a sickle cell anemia, and if there is 1 mutated beta gene present, then it is the sickle cell trait. Now next important topic, that is the jaundice. Now what happens in the jaundice? There is yellow discoloration of the skin, including the under tongue, sclera, and thin skin. Okay, if anyone asks that what is the first location where jaundice is seen in the body? So remember, under the tongue. Okay, the first sign comes under the tongue. The under the tongue becomes yellowish or less reddish in color. Then sclera, and then finally the skin. Okay, jaundice doesn't appear directly onto the skin. First of all, under tongue, then the sclera, and then the skin. Now over here there is increment in the serum bilirubin level, and over here there is more than 2.5 milligram per dl of the bilirubin level in the body, leading to yellow discoloration of the under tongue, then sclera, and then the skin. So over here, first of all, the prehepatic jaundice. Now how does this jaundice occurs? Because of the increment in the bilirubin. Okay, and we have seen that what happens after the destruction of the RBCs, there is bilirubin formation. Excess destruction of the RBCs, or we can say hemolytic jaundice, or we can say prehepatic jaundice, means extra, means over breaking down of the RBCs leads to the prehepatic jaundice or the hemolytic jaundice. So in this prehepatic jaundice, there is free bilirubin in the blood, it is increased. Conjugated bilirubin in the blood, it is normal. Conjugated bilirubin in the urine, it is nil. And urobilinogen in the urine is increased. Remember this whole table, understand and remember, this is very important. Okay, these all concepts, these are increment, decrement. Okay, just understand this and remember this, because these are commonly asked in the exam, and not only for the exam, for general knowledge also. These all are very important. Okay, so remember, in the prehepatic jaundice, as the name says, prehepatic, that means hemolytic jaundice, means normally the liver is associated with the jaundice, right? But prehepatic means previous to the liver. Okay, before the liver. So hemolytic jaundice is the prehepatic jaundice, and over here all such conditions occur. Okay, I have made a separate video on jaundice. This is, if you want this jaundice to be like, if you want to understand in detail, just click on this I button somewhere over here. Okay, and you can just get the detailed information, detailed concept, understanding of this whole jaundice in a very nice and easier manner. Okay, click on this I button if you want it in detail. Now next is the hepatic jaundice in the liver. Over here the free bilirubin in the blood is increased. Conjugated in the blood, it is increased. Conjugated bilirubin in the urine, nil. Urobilinogen in the urine, nil. I have explained this whole concept in my jaundice video. Okay, just click on this I button somewhere over here. Okay, you can get the easiest explanation of this whole in detail, because this is a very huge concept. Now next is the causes of the jaundice. Till now we understood the types of jaundice. Now the causes of jaundice. Now first of all, we have is the extravascular hemolysis. Okay, or we can say ineffective erythropoiesis. Now what happens in the extravascular hemolysis? There is increment in the unconjugated bilirubin. How? Just look at this diagram. Because over here there is excessive destruction of the red blood cells. What is happening? There is increment in the hemoglobin, which further causes increment in the unconjugated bilirubin in the blood. Okay, and because of this, what is happening? There is increment in the unconjugated bilirubin. Okay, but you might think that this bilirubin might go inside the liver and become conjugated. But because of excessive breakdown of the RBCs, what is happening? There is increment. There is a lot increment in the unconjugated bilirubin, which the liver is not able to conjugate. So that's why jaundice occurs. Now next is the physiologic jaundice of the newborn. Over here, remember, in the extravascular hemolysis, there is dark urine seen, and even there is increased risk of pigmented bilirubin gallstone. Okay. Now next is the physiologic jaundice of the newborn. Now in the newborn, there is this enzyme. There is lower amount of this UDP glucuronide transferase enzyme. This enzyme is in a very low amount in the newborns. In the newborn babies, this enzyme is very less. So that's why what happens? The kidney is not able to conjugate the bilirubin. That's why again in this jaundice, there is increment in the unconjugated bilirubin in the body. Okay, and also kernicterus is seen over here. Kernicterus jaundice is seen over here. The next is the Gilbert syndrome. Now over here it is an autosomal recessive disorder, and because of autosomal recessive disorder, there is lower amount or less amount of UDP glucuronide transferase, this enzyme activity is reduced because of the autosomal recessive disease, that is a Gilbert syndrome. This enzyme activity is reduced, leading to increment in the, again, unconjugated bilirubin. The next is the Crigler-Najjar syndrome. Over here, this enzyme is absent. So what is happening? In the newborns, this enzyme is very less. In the Gilbert syndrome, the activity is decreased of this enzyme, and the Crigler-Najjar syndrome, over here, the enzyme, particular enzyme is absent. Now next is the Dubin-Johnson syndrome. Now what happens in this? How does this cause the jaundice? So over here there is deficiency of the bilirubin canalicular transport protein, and that's why there is increment in the conjugated bilirubin. There is increment in the conjugated bilirubin because of the deficiency of the bilirubin canalicular transport protein, and this causes the liver to appear darker in color. Now next is the biliary tract obstruction. Now this comes under the post-hepatic jaundice. Okay. Now what happens because of the gallstone or pancreatic carcinoma? What happens? There is obstruction occurring, leading to the jaundice. And over here, remember, there is increment in the conjugated bilirubin. This conjugated bilirubin is increased over here. Okay, which causes the urine to appear darker in color, stool to appear pale in color. Also, steatorrhea is seen over here. Also, viral hepatitis may cause jaundice. Okay, and it causes increment in the conjugated bilirubin, and even it causes increment in the unconjugated bilirubin. White blood cells. Now, white blood cells, we all know what is white blood cells. White blood cells plays the major role in the defense mechanism of the body. Normal range, you should remember, 4500 to 11,000 per microliter of the blood. And these, the amount of all this, you should remember: neutrophil, lymphocyte, monocyte, eosinophil, and the basophil. Remember all this, these digits. These are very important, commonly asked in the exams. Now, phagocytosis. The WBC acts as the important defense mechanism, and they causes the phagocytosis to occur. So, neutrophils are the major cells that carry out the phagocytosis process, and they play an important role in the bacterial inflammation, thus called the first line of defense against the bacterial infection. Very important. Now, the steps including in the phagocytosis. So, first step, it is the margination. Okay, as you can see over here, these neutrophils are coming towards the particular area, margination. The next step, it is the diapedesis step. Now, over here what happens? This neutrophils migrates from this bloodstream. This is the bloodstream. So it migrates from the bloodstream into the tissue. As you can see, it is migrating from the bloodstream into the tissues by passing through the junction between the endothelial cells lining the blood vessels, and this step is known as diapedesis. Simple way, migration of the neutrophils from the bloodstream towards the or into the tissue. Now next is the chemotaxis step. What happens in this step? Just in a simple way, remember what happens in this chemotaxis. The neutrophils interacts with the bacterial products, and because of this they produce the chemotactic agent. As the name says, chemotaxis, they produce the chemotactic agents that attract the neutrophils to the site of the injury or inflammation, leading to chemotaxis. And because of this, what happens? Neutrophils adhere to each other also. Now next is the opsonization step, a very interesting step. What happens in this step? Opsonins coats the bacteria and make them tasty to the phagocytes, leading to a process that is the opsonization. Means simple, opsonins coats the bacteria, making them tastier. Now the opsonins are naturally acting factors and includes the IgG and the opsin fragments of the complement protein. Now next is the phagocytosis process occurring. Then the degranulation process occurs. Over here, the phagocytes engulf the bacteria, right? Now as the bacteria entered into the phagocyte, what will happen? Bactericidal substances known as the defensins. What are defensins? They are the lysozymes and the peroxidases inside the phagocyte. They all are released from the lysosomal granules, and what they will do? They will kill and digest the bacteria, right? And this process, that's why is known as the degranulation. That means whatever the defenses are released from the phagocytes inside the digestive pouches in the phagocyte, they will kill and digest the bacteria, leading to degranulation process. After this, what will happen? Inflammatory responses occurs because of the histamine and the serotonin release in the ECM. And finally, limiting the inflammation, and this is maintained or this is caused by thromboxanes and the prostaglandins. Now next is the platelets and their functions. So normal range of the platelets, it is around 1.5 lakhs to 4.5 lakhs per microliter of blood. Now these platelets contain various granules which are released when platelets are activated and perform a number of important functions. Now which are these granules? So these are dense granules and the alpha granules. Dense granules contain the ADP and the serotonin, while the alpha granules contains the clotting proteins and the platelet derived growth factors. Now what are the functions of the platelets? The platelets play a very major role in the hemostasis process by forming a platelet plug. Now as you can see over here in this diagram also, this is the platelet plug. Now they form a platelet plug at the site of the injury, which helps to arrest the bleeding, to stop the bleeding. So they form the platelet plug. Now also they secrete the serotonin. They secrete this. What is serotonin? It is a very potent vasoconstrictor, right? And this potent vasoconstrictor helps in arresting of the bleeding in the earliest stage. So it forms a platelet plug and releases this potent vasoconstrictor, serotonin. Also, it plays a major role in coagulation by producing platelet factor 3, which helps in conversion of the prothrombin to thrombin by factors 5 and 10. Now, next important function, it is the clot retraction. Platelets contain contractile proteins, right? And they contract and causes the shortening of the fibrin fibers attached to them, leading to clot retraction. Another function, it is a phagocytosis. Okay, and finally, storage and the transport function they do. Now, this is the idiopathic thrombocytopenic purpura. Now, as the name says, what do you think? What is this? This is the clinical condition which is occurring because of a decrement in the platelet count in the body. Now, very important concept, that is the blood grouping system. Okay, so before going into detail, okay, we all know we have blood group A, B, AB and O. They are the common one. We have further many types of blood groups. Okay, blood groups. But this AB blood group system, it is the most common blood group system, the ABO blood group system. Over here we have A, B, AB and O. So we all know what happens over here. In the A blood group, the antigen A is present on the RBC, while the antibody B is present in the plasma, in the blood. In the B, opposite thing happens. In the AB system, what happens? On the RBCs, antigen AB present, while in the blood, in the plasma, there is no antibodies present. That's why the AB is the universal acceptor. Okay. While in the O, they have no antigen present on this RBC membrane, while both anti-A and anti-B antibodies are present in the plasma, the blood. That's why, because of this, the O is considered as the universal donor. Now, very important law, that is the Landsteiner's law, commonly asked in the exam and even important for our concept understanding also. Landsteiner's law is related to the blood group system, and it states that if an agglutinogen is present on the red blood cell, the corresponding agglutinin must be absent in the plasma. For example, over here, if the blood group agglutinogen A is present on the RBC, antibody A will be absent in the plasma. As you can see over here, what does it say? It states that if an agglutinogen, that means antigen, if a particular antigen is present on the red blood cell, the corresponding antibody agglutinin should be absent in the plasma. Okay, I told you before also. In the A, antibody B is present in the plasma. In the blood group B, antibody A is present in the plasma, and rest all. Okay. It further states if agglutinogen is absent, means if the antigen is absent, the corresponding antibody agglutinin must be present in the plasma. Now, this law does not hold good in the Rh type of blood grouping. In the Rh positive person, antigen D is present on the RBCs and antibody D is absent in the plasma, while in the Rh negative individual, though the D antigen is absent on the RBC, antibody D are naturally absent in the plasma. Okay, so this doesn't holds good in this law. The Lansner's law doesn't hold good for the Rh type of blood grouping. Now, incompatible blood transfusion and the dangers of the blood transfusion. Incompatible transfusion or the mismatched transfusion means that the cells of the donor and the agglutinins of the recipient are not matching, and as a result the RBCs in the transfused blood are agglutinated by the agglutinins in the recipient plasma, leading to mismatched blood transfusion reaction. This can occur due to the ABO incompatibility or Rh incompatibility. Now, what are the effects of the incompatible blood transfusion? Commonly asked in the exam and even important for a practical purpose. Firstly, inapparent hemolysis. Now, how does this post-transfusion jaundice occurs? Because of the breaking down of the RBCs, because of the hemolyzed RBCs, there is increment in the hemoglobin in the body, and because of this, the hemoglobin get metabolized to bilirubin, producing the hemolytic jaundice. We discussed about this before also, right? Now, severe reactions with the hemoglobinuria and the renal failure. After a few ml of blood has been transfused, the patient complains of violent pain in the back and tightness in the chest area. Why? Because of the agglutinated RBCs forms the clump that can block the capillaries, and this can also lead to oliguria. Now, next is the mechanical overloading. Now, this mechanical overloading leads to hypervolemia. Now, chemical risk. As the stored blood loses the potassium ions to the external plasma, therefore, following excessive transfusion, death may occur due to the hyperkalemia. And with the massive transfusion of citrated blood, normal conversion of citrate to the bicarbonate may be delayed. That's why all such chemical risk may occur. Patient may suffer from lack of ionized calcium, producing tetany, and alkalosis may develop in the patient with defective kidney functions. So this is very important to be understood. Okay. Now, pyogenic reactions may also occur, including the fever with chills and the rigors. Also, allergic reactions may also occur, like rashes, anaphylactic shock, angioneurotic edema, and even urticaria. Transmission of diseases like malaria, syphilis, AIDS, and jaundice may also occur. These is the very important topic, that means dangers of the blood transfusion. Now, what is the clinical importance of identifying the Rh factors? So, firstly, when the blood transfusion is to be given, Rh factor must be considered. Otherwise, blood transfusion reactions may occur. And also to prevent the erythroblastosis fetalis, okay, seen in the Rh negative mother. Now, next is the clotting mechanism. Hemostasis is a collective term used for various body mechanisms which arrest the bleeding and hence prevent the blood loss via the spasm of the local vessels, which causes the vasoconstriction, platelet plug formation, and also blood coagulation. Now, you should not confuse between hemostasis and homeostasis. What is homeostasis? That means maintaining the internal body environment regardless of the change in the external environment, while hemostasis, that is the clotting mechanism. Just remember the difference between these two. Okay, mostly students get confused between these two. This is the hemostasis and this is the homeostasis. Okay, now the clotting factors, very important. All these 13 factors you should remember. Now, the hemostasis process. Hemostasis is the spontaneous arrest or the prevention of the bleeding by the physiological processes. So, firstly, the spasm or the constriction of the injured blood vessels occurs, and it is due to the mechanical stimulation and releasing of the 5-HT, that is the serotonin, from the tissues, which is a potent vasoconstrictor. We discussed this before also, right? The next is the collection and the aggregation of the platelets at the site of injury, forming a temporary hemostatic plug, that is a prompt response. Finally, there is conversion of the temporary hemostatic plug to definitive plug, the definitive hemostatic plug. So these are the steps, okay, for the forming of the clot. spasm of vasoconstriction, then forming the temporary plug, collection and aggregation of platelets, forming the hemostatic plug, but this plug is temporary, and finally forming the permanent or definitive hemostatic plug. Very important, hemostasis clotting mechanism process. Now next is the mechanism of the intrinsic and the extrinsic coagulation. So first of all, the intrinsic pathway. This intrinsic pathway is activated either in vivo, by in vivo pathway, or in vitro pathway. Now in vivo, this intrinsic pathway is activated when the blood clotting factors comes in contact with the collagen of the damaged vessel wall and change in the blood constituents. While in vitro, this intrinsic pathway is activated when the blood comes in contact with the wettable surfaces like glass. So in vivo means this intrinsic pathway is activated when the blood clotting factors comes in contact with the collagen of the damaged vessel, and in vitro, that means when the blood comes in contact with the wettable surfaces like the glass. So these all steps are included over here. Over here, kallikrein and the high molecular weight kininogen are included. They will cause the 12th factor. They cause the activation of this 12th factor, and it further activates the 11th one, then 9th, then 10th, which further in the presence of the 5th one causes the prothrombin activation, which is the step 2, which comes under step 2. The step 2, the prothrombin is activated and it's converted to the thrombin. And then finally in the third step, this thrombin converts the fibrinogen to fibrin in the presence of calcium. Okay. Now next is the extrinsic pathway of the clotting mechanism. Now this pathway is triggered or stimulated by injury to the blood vessel wall and other body tissues, causing releasing of the tissue thromboplastin 3. Remember, tissue thromboplastin 3, and this further leads to activation of the 7th factor. Now further it activates the 10th, and again it causes the activation of the prothrombin, which further goes on to the same pathway like the first one. Changes was only over here in the first step, in the first stage. Now very important concept about the hemophilia. Hemophilia is a clinical condition in which the clotting time is prolonged due to the congenital absence of the anti-hemophilic globulin. Now next is the mechanism that keeps the fluidity of the blood. So over here, blood is kept in the fluid state as a result of a balance between the clotting and the anti-clotting mechanism. The mechanism which prevents the clotting, they are smooth vascular endothelium lining the vessels, anti-clotting mechanism. Anti-clotting mechanism includes the antithrombin 3, thrombomodulin, plasmin, and the heparin. So these are the anti-clotting factors or anti-clotting mechanism. This is the fibrinolytic system. Such system and also the anti-clotting factors and the mechanism inhibits the clot formation in the blood. Now next is the anticoagulants. It can be natural or in vitro. Natural includes the heparin, protein C, fibrinolytic system, and the in vitro includes the oxalates, sodium citrate, EDTA, heparin, etc. Now this is the table, very easy table for understanding the various components of the blood used for the transfusion, for the blood transfusion. These all components of the blood are used for the blood transfusion process. Now next is the immunity. What is immunity? It is a complex biological system endowed with the capacity to recognize and tolerate whatever is self, whatever belongs to the self, and to recognize and reject what is non-self or foreign. Immunity is for two types, innate and acquired. Acquired is further of two types, natural and artificial, further of active or passive types. Okay. So, first of all, the innate and the acquired immunity difference. Very important, commonly asked in the exams. Innate present right from the birth, acquired during the course of life. Its response occurs within minutes, innate immunity, while for acquired response occurs in days. innate, no prior exposure to antigen is required and having the limited diversity, while the acquired is developed after or following the antigen exposure and they have variable diversity. No immunological memory present. It is present, memory present. Host cell receptors are not specific, while over here they are specific. Toll-like receptors are involved. Over here, T and B cells are involved, immunoglobulin involved, and remember this acquired or adaptive immunity is further divided into two types. That is active and the passive immunity. Okay, these are the example of the innate and the acquired. It includes phagocytes, dendritic cells, complement, NK cells. Over here, we have B lymphocytes, plasma cells, antibodies. This means B and the T lymphocytes mainly. Okay. Now next is the difference between the active and the passive immunity, commonly asked in the exams. Antibodies are developed or produced by the body's own immune system in response to the antigens introduced naturally or artificially in the body. Active immunity develops after a latent period of 4 days to 4 weeks, which is required for generation of antibodies and immunocompetent cells. Due to the immunological memory, the secondary response is more enhanced. This is long-lasting. It is more effective and confers better protection. Active immunity is not applicable in the immunodeficient individuals, while for the passive, produced by administration of the ready-made antibodies to the host, there is no latent period as passive immunity is effective immediately. There is no immunological memory because subsequent administration of the antibodies is less effective due to immune elimination. This is short-lasting. This is less effective and provides inferior immunity. Also, it is applicable in the immunodeficient individual because we are administrating the ready-made antibodies to the host. Okay. And next is the cell-mediated immunity, which includes the T lymphocytes. This involves the T lymphocytes that are further divided into 4 types: cytotoxic, helper, suppressor, and the memory T lymphocytes. This does not involve the production of the antibodies because the antibodies are produced by the B cells, the B lymphocytes, which comes under the humoral immunity. While over here antibodies are not produced by the cells, by the T lymphocytes. It is responsible for delayed allergic reaction, rejection of the transplanted foreign tissue, and lysis of the tumor cells. Now, the effect of stimulation. The T lymphocytes encounters the cancer cell. Okay, these are the steps. Okay, how does the cell-mediated immunity occurs? So, the T lymphocytes encounters the cancerous cell, which further causes the activation of the T lymphocytes. Now, what will happen? They release the lymphokines, and further cytotoxic T lymphocytes attacks the cancer cell, and this causes the elimination of the cancer cells. T lymphocytes are a type of lymphocytes which are processed in the thymus gland to gain the maturity for providing the immunity against the disease. T cells are responsible for providing cellular immunity and provides defense against the infections such as virus, fungi, some bacteria. They are responsible for delayed allergic reaction, rejection of foreign tissue transplant, defense against tumor. There are 4 different types of T lymphocytes, very important. That is the helper or the inducer one. We discussed about this before also, right? Suppressor, cytotoxic, and the memory. Okay, these are the 4 different types of T lymphocytes. Now, humoral immunity, that is the which involves the B cells. Humoral immunity is a defense against foreign antigens by elaborating antibodies against them in the circulation. Over here, antibodies are formed. Immunoglobulins are formed. Antigen may be bacteria, virus, or any other foreign protein. Antibodies are produced by the B lymphocytes, which are processed in the gut-related lymphoid tissues. Antibodies are gamma globulins and a specific type of antibodies produced in response to specific foreign antigen. Now, their effect, their stages. B lymphocyte encounters the bacteria, which further causes the plasma cell formation, which causes secretion of the antibodies, and further antibodies attacks the bacteria and bacterium eliminated by the phagocytosis. Simple. B lymphocytes are responsible for humoral immunity divided into 2 types, plasma cell and the memory cells. Development takes place in the liver, spleen, and bone marrow. major defense against bacterial infection. Now the steps involved in the production of the antibodies. So as you can see, this is a very clear diagram of how the antibodies are produced. First of all, the antigen is ingested by the macrophages. After ingesting, what the macrophage will do? Macrophage expose the antigens. Macrophage will expose the antigen and the protein of the MHC, that is the major histocompatibility complex, on their surface. Now after exposing them, macrophages then comes in contact with the T cells. And what they will do? They will activate the helper T cells, that is the T4 cells. Okay. Now the T4 cells in turn stimulates the B cells. The helper T cells stimulates the B cells. Okay. Now the B lymphocyte or B cells are activated and they proliferate and they produce their further types of cells, that is the plasma cell and the memory cell. And the plasma cell. So what happened till now? Ingestion of the antigen by the macrophages, then exposing the antigen and also MHC on the surface of the macrophages. Then the macrophages in turn will comes in contact with the T cells and they will activate the T cells and they will mainly activate the helper T cells, the T4 cells, and they will stimulate them. And further, this helper T cells will stimulate the B cells. Now this B cells will then produce the memory cell and the plasma cells. Okay. Now the plasma cells then secrete large amount of antibodies, okay, which are gamma globulins and also known as immunoglobulins. Okay. And this memory cells, the memory B cells, respond quickly when the body is exposed to the same antigen in the future. Now next is the NK cells, that is the natural killer cells. Now what are these NK cells? They are special type of cytotoxic lymphocytes, also called as non-T or non-B lymphocytes. Okay. Now their main certain characteristic features of their actions include that they kill the antigen without any prior sensitization and without the involvement of the major histocompatibility gene. Also, they destroy the cancerous cell and they help in prevention of the cancerous condition, a very important function of them. Also, they attack the viruses, killing the antibody-coated viruses, and their activity is increased by the interleukin 2. So, interleukin 2 increases their activity. They represent an important first line of defense against the viral infection. Immunoglobulins, one of the most important questions. Now, as you all know that the B lymphocytes, they are responsible for humoral immunity, are divided into plasma cell and the memory cell. And the plasma cells secretes a large quantity of antibodies that circulate in the gamma globulin fraction of the plasma and are known as immunoglobulins. Okay. So now over here, the immunoglobulin, as you can see, contains over here 4 polypeptide chain, 1, 2, 3, 4, 2 identical light chain and 2 identical heavy chain, and they are joined by the disulfide bond. Also, both the heavy and the light chains contain 2 different types of region in them, that is the constant region, this blue color region, constant, and the purple region, that is the variable region, and over here there is hypervariable region, and from this over here the antigen binds to the antibody. The epitope region of the antigen binds to the paratope region of the antibody. Immunoglobulins are divided into 5 types based on the differences in the constant region of their heavy chain. Okay, and they are IgG, IgE, D, M and A. So first of all, the function of the IgG. IgG are involved in the secondary immune response against the major antiviral, antibacterial and antifungal activity in the serum. They may also serve as opsonins and promote chemoprotective activity of WBC. And remember, this IgG can cross the placenta and even is present in the breast milk. The next is the IgE. IgE plays a very important role in the allergies, skin infestations, parasitic infection and also anaphylactic type of immediate hypersensitivity disorders, mainly related to the allergic reactions. Now IgD. Now they are present on the surface of the B lymphocytes with IgM. Therefore, they are involved in the antigen recognition. The next is the IgM. IgM are mainly involved in the primary immune response, and also they activate the complement system, promote the phagocytosis, and also causes the cell lysis. The next is the IgA. IgA occurs in the plasma and also secreted in the tears, saliva, intestinal juices, respiratory secretion, and also in the colostrum, where they provide the localized immunity. So yeah, that's all for today. I hope you found this video helpful. I have tried to gather all the important questions as I can in this video about the blood chapter. And very importantly, if you want to know about the anemias, different types of anemias, vitamin B12, vitamin B9, iron deficiency anemia, just click on the I button, and even I have given the link of that videos in my description box. Just go over there and just watch that video of anemia. I have given the easiest possible explanation about them. It will be easier for you only. And in the part 3, I will be discussing the excretory system chapter. So that's all for today. Thank you so much.